You're listening to Airey Bros Radio. Be there or be square, because it's all killer, no filler.
A treatment now that people need to know about, that it's out there and it's a good option for people. Like how the whole clinic evolved into from a ketamine infusion center to like a whole wellness center is I've always been interested in like whole body wellness, taking care of your body. You take care of your body, it's going to take care of you. The patients that come in seeking treatment are almost as knowledgeable as I am about the medication. They're a 35-year-old healthy male who works out, and eats right, and their level's 270 and normal's like 250 to 800. And the doctor's like, well, it's in the normal level or normal range, but yeah, for an 80-year-old man, you're in the normal range. As the clinic evolves, we're going to work our way back into, if ketamine didn't work, then there's got to be something else, or there's most likely something else that is affecting your depression or causing your depression or your anxiety, or something else we could optimize. This is Jason Blasenak, and you're listening to Airey Bros Radio.
Through this journey, we've gotten more into, I guess, maybe as some people call like the woo-woo side of things, or the spirituality. And we've gone into, mindful practices and just overall optimization and helping people. So we've gone down the rabbit hole of, like I said, with plant medicines and helping people with PTSD. And so we've had people from that realm. Like I said, we had 2 people from the ketamine clinic. So I'm curious about your background. Are you originally from South Carolina? How did you get here if you aren't? And then how did you get to doing what you're doing?
Yeah, so I originally was born and raised in Dayton, Ohio. I did undergraduate at Butler University in Indianapolis and played college football there. I initially had injured my knee when I was 16 doing squats, had surgery on my right knee, had part of my meniscus removed, and just fell in love with medicine and the ability of a physician to get an athlete back in playing. So basically from the time I was a junior in high school, my goal was to do or to practice medicine essentially. So ended up getting into school in Des Moines, Iowa at Des Moines University, and did my 4 years of medical school there right after my 4 years of undergrad. And then did internship in Erie, Pennsylvania, and ended up in Joplin, Missouri, which is the far southwest corner, for residency. I initially wanted to do orthopedics, kind of like I was helped by the orthopedic surgeon, and then realized that I didn't want to be on call every other holiday and, every other weekend. And I liked the procedural aspect of emergency medicine. So I ended up going into emergency medicine. Knew that I wanted to be near the mountains when I graduated, and Denver, Colorado was the #1 place where you cannot get a job unless you knew someone. Because I actually did my toxicology rotation and my trauma rotation out there, and the job market, you literally had to be like the creme de la creme to get a job out there unless you knew someone. So started looking at other places, Nevada, Northwest Arkansas, and then Greenville, South Carolina kind of popped up. And, I was interested because it had pretty good mountain biking, and I was a pretty good mountain biker at that point. And so kind of everything worked out with the job. It was exactly what I was looking for. And, an hour and a half to the mountains to do mountain biking, and not as tough as out in Colorado, but it still pushes you a little bit. So ended up here. And I've been in and around the upstate or the low country for the last 18 years.
Okay. So you're quite well traveled and versed across the United States like we are. When were you in Colorado?
I was in Denver. So I did. Yeah.
When was that?
It was 05. So
Okay.
February and August of 05, I was at Swedish Medical Center and at Denver General.
Okay. Cool. Yeah, I think the terrain down here, the technicality of the trails on the East Coast is, I think it gets slept on a lot by a lot of people. Like west of the Mississippi, they think that they have the hardest trails and all that. And I know I've stepped on quite a few routes, and I will take high elevation over high humidity any day of the week.
Absolutely.
Yeah.
Jason, you mentioned getting involved in the ER side of things in your training, and what you do. Where does ketamine come in with that?
So basically, even when I was in residency, which was 2003 to 2006, we were using ketamine basically for sedation for patients. And most likely it was pediatric patients. So, if they had broken a bone and you had to reset the bone, basically you were giving them ketamine as their anesthetic because of the low side effect profile, especially for those kids. And so I ended up using, an extraordinary amount of ketamine throughout my career and was very familiar with it. And then, I would probably use it 300-400 times a year, but it was always in the procedural sedation side. And then I realized, like, as you work in the ER, you realize how bad the mental health, and just the physical health of society has gotten over the years, and it's progressively worsening. So about 2016, there started to be research starting to come out preliminarily about treatment of, treatment-resistant depression, PTSD, chronic pain with low-dose ketamine infusions as opposed to like sedation dosage of ketamine. So I became interested then, but it was still kind of on the fringes, and especially in South Carolina, probably not a whole lot of people were utilizing it as they were out in California, or in Colorado, New York, Florida. And so I always kept an eye on it. And then over time, it finally got to the point where I felt that right now is a good time in South Carolina because there's not enough clinics out here for the patients that need ketamine treatment. And the landscape's starting to become very favorable with the research to allow these clinics to operate, even though it's not technically FDA approved at this point for IV infusions of ketamine.
And being in South Carolina, was that something that was difficult to get started with, how, I guess, conservative they are about things like that down here?
And I wouldn't say that it was difficult. You can basically open up a physician's office and infuse ketamine. The question and a lot of the problems is that most of the malpractice companies want you to be either a psychiatrist or a anesthesiologist, one of the two, who have given ketamine and monitored these patients, and they kind of make it very difficult for someone who's done emergency medicine training to get certified or to get covered with malpractice coverage. So I wouldn't say opening up the clinic, because anybody could open up a physician's office in the state and offer ketamine, but whether they can do it and get malpractice to cover for it is another story.
Okay, interesting. And from my side of things, in my research, it was used as like an anesthesia up until the Vietnam War, and then was maybe still used for children. And then as a club goer and stuff, you always heard about being like, oh, that's the cat tranquilizer, or that's the animal tranquilizer. That was in the late 90s, early 2000s. So when did it come back into, because I remember hearing about it again in, I guess it was like 2015 or 2016. There was that incident with the guy in Colorado who I think they maybe gave him too much and he ended up dying. It was, and I had a friend who was an EMT, and she had said that they were using it in emergencies when they were using the ambulance and stuff. Had it always kind of just been under the periphery, and then it kind of got bastardized with the club scene and all that stuff?
Yeah, that for the most part, I think that was the biggest issue with it, because there'd actually been research on IV infusions helping depression all the way back to the late 90s and early 2000s. And once we started having the club issues with it, it was definitely bastardized at that point. Because like I said, I didn't even know about it for treatment-resistant depression because there was only 1 or 2 papers about it back in the late 90s, early 2000s. And so no one was really using it except for major research centers. And even then, these studies were 20, 30 patients. And so I think, until that kind of died down, people weren't willing to kind of do other research studies that could advance this a little bit further. And then as they realized how safe ketamine is, even from a sedation perspective, I mean, it's very hard to overdose people unless you give them just a humongous dose, and overdose them for them to have any major side effects. The only real bad side effect is they can slow their breathing down enough that it could potentially stop, is one of the biggest things. Their blood pressure can kind of go sky high if you give them too big of a dose. But other than that, there's not a whole lot of other side effects except for very, very rare side effects that you see. And usually those are mitigated by giving the infusion over an extended period of time. So if I give them a sedation dose, I'm pushing the ketamine over a minute and I'm giving them like 1 milligram per kilogram. If I'm infusing them, and then I'm doing it the 0.5 milligrams per kilogram. And do it in over 45 minutes. So I think as it became more what they considered a safer risk profile, and multiple EMS units carry it now, especially even in the South. But before, California, Colorado, New York, they were carrying it on EMS in the late 2000s, and then had just continued that because they realized that the safety profile for that versus giving opiates like morphine or Dilaudid was so much better to deal with ketamine, and its pain control was significantly better as well compared to the side effect profile. And so once EMS started using it and they realized that it was safe, I think that's when some of the research studies have realized that they could actually start pushing the envelope, I'll say, on actually getting out the dosages for the treatment-resistant depression, anxiety, that type of use of ketamine.
Jason, you brought up before how you saw the benefits of using it in the ER for low-dose anesthetic. And you also mentioned that there was only 2 papers on depression and how it worked with depression. Where did you come to that point in your practice and in what you do where you knew that it could help for depression? Did you have a personal experience? What kind of got you there?
So I started using it almost in the emergency department in some regards, in regards to like depression. So people that had acute pain, or if they were very anxious and they'd come in almost panic attacky, I would try that dosage, or try a dosage of ketamine on them and infuse it instead of pushing it like for sedation, and use a much smaller dosage. And we were seeing miraculous results. So I would have people with migraine headaches, which it's indicated for, who would come in and you'd give them a sedation or a infusion dose over that period of time. And so we were seeing a lot of benefits in the emergency department. And I guess I should go back. I had my own urgent care clinic from 2015 until 2018, early 19. And so I was seeing a lot of migraine patients there that we were giving infusion dosages for, who were getting fantastic results with low side effects. And those were the ones that you couldn't treat them with the standard medications like Imitrex or Toradol or those type of medications that they normally would get treated in the emergency department. And I was giving that dosage in my urgent care center and getting excellent results. So it mostly was anecdotal, and that was about the time that some of the literature was starting to come out about how effective it was. And so I felt that that was the perfect time to trial it for myself and see how effective it could become.
So did you have any personal experience with it before you opened your clinic that you have now?
Only the experience that I had in the urgent care center. Yeah. So I had my urgent care from 2015 to 2018, and I would use it then. But as for using it for absolute treatment resistant depression, anxiety, PTSD, not until I opened my clinic now.
So you mentioned doing kind of your own case studies at your urgent care clinic. At what point did you say, all right, I'm going all in on this and we're going to open up a clinic?
Yeah. So when I owned the urgent care, I had a business partner, and we did not see eye to eye. And so
on this particular topic, or just in general? Sorry to cut you off.
No, just in general.
Okay.
Yes, it was a difficult working situation. And so I decided to leave my practice at that time and split from him. And so because it was not a friendly split, then I ended up having to litigate matters with him. And so as we're coming to close with litigation, I realized that I had enough financial backing and I wasn't going to have a significant amount of capital outlay and lawyer fees as we were getting ready to close that. And so that's what made me jump and open up my own clinic. I probably would have done it 2 or 3 years earlier if I would have had the assurance that this was not going to get litigated for a extended period of time, 5 to 7 years.
Okay. Taking a step back real quick, and then I want to get into opening. You said like a sedation, you did 1 milligram per kilogram, correct?
Correct. Yes.
And then it's a half a milligram per kilogram for intravenous, like slow.
For the slow infusion, correct.
So is it always based off of the dosage is always based off of body weight or size of the human?
So there's a little bit of play with this. And so most of the protocols indicate that the most effective amount of ketamine is that if someone's never had it before, or if they've only had it for sedation, that you give them 6 treatments over a 2 to 3 week period. And so because there can be issues with, hallucinations and how they perceive things, I'll usually give them a smaller dosage than the 0.5 off the bat, see how they do, and then we can amp up or increase the dosage over about a 3 visit span, and then I'll know that they can accept the 0.5 milligrams per kilogram. There's really nothing, and that's where a lot of the problems now come with the literature, is that there's so many variabilities with the protocols, and some of them just have the standard protocol of the 0.5 milligram per kilogram. I think everybody's a little bit variable, and I think that we're excluding a fair amount of people who have a bad reaction with that first higher dose if they've never been exposed to it before, that we're going to miss a lot of people that would benefit greatly from ketamine by amping up the dosage right away, as opposed to kind of gradually increasing it. So I like to try to gradually increase it, and then we'll increase or decrease the time window in between treatments as well, so that hopefully they get very, very effective treatment, without the major side effects that could potentially come from it.
Okay. So I want to get into the treatments and stuff, but I'm curious, were you the first one in South Carolina to have a ketamine clinic?
No, and that's the funny part. There was actually a doctor in Charleston who opened up in the late 90s. And
Really?
yeah, and he'd had his clinic, he's had his clinic since then and has had no issues with his clinic. There's a clinic in Columbia now. There's 2 clinics in Greenville. There's a clinic in Rock Hill, and then there's at least 1 clinic in Myrtle Beach that I'm aware of. So, but compared to most other states which have, or cities, especially in some of the bigger cities, like Florida has hundreds of these clinics at this point. California has hundreds of these clinics. So in the grand scheme of things, South Carolina's, although started fairly early with the 1, it really didn't start to expand until the last 4 to 5 years, when I think that it became acceptable, or more acceptable, for people to start, or for physicians to start these clinics.
Yeah, I mean, I'm still fascinated by the fact that there are, yours, and you mentioned the ones in Greenville. I didn't know there was one in Rock Hill. So just being here and seeing how people view things, it does blow my mind that they do exist. I'm happy that they exist. I think it's a great thing. And I just was, when I first saw the post, I was like, holy cow, I got on the computer right away, and then I contacted Rob, and yeah, here we are. But that's awesome.
Yep. Yeah. So it's, like I said, and I don't know, I have some of my patients who had been going to the Greenville clinic who were driving an hour and a half to get treatment. And I think that's a lot of the issue, is that number one is access. There's, unfortunately, because it's not covered by insurance, then there's a lot of problems with access to, a lot of people that need it. A lot of service members that I've seen that have had PTSD, would benefit greatly from this. And it's few and far between that you can get the VA to cover this treatment. And, I will admit that most people just can't afford, the type of amount of money that they would have to pay for this treatment. And if it's going to be effective for them at all, and that kind of hinders a lot of people from being able to treat. There is like a nasal spray that can be covered. It's not near as effective as what the IV infusion is based on what the literature says. I mean, there's troches that you can dissolve basically in the mouth. Also, it's just not absorbed well. And I think there's probably a lot of variability in the absorption. So the IV infusion, I feel, is the best solution for this, but I guess at this point, it's just not covered with insurance, and it's very costly, even in South Carolina.
Do you see any headway with that in terms of it being something that's covered under insurance, or that's still going to be a roadblock for a while?
I think it's probably going to be a roadblock for another 3 to 5 years. I mean, I think that we're making progress between the studies with psilocybin and the other type of psychedelics that are out there. And I think that if they show the promise of what they've shown currently with like the studies out of Johns Hopkins currently, then I think that there's going to be more acceptance that ketamine is less of a risk than something like psilocybin for insurers to possibly go and cover at that point. So that's my hope. Everything, if it's the VA, everything's going to move slow because it's the government. So I think that 3 to 5 years would be an optimistic timetable, where I would hope that we could get at least a couple of insurers in network where they're going to cover benefits for people, because I think a lot of times it's going to keep people out of the emergency department from, their thoughts of suicide, their ability to function in life, where a lot of these people they can't hold a job because they just can't get out of bed, or the anxiety that they have. I mean, anecdotally, I had a patient, she just went through treatment. She did fantastic. And I got a text from her father who, told me, I haven't seen that girl in, 6 or 7 years. And I mean, what a wonderful thing, he had now that he's got his daughter, or what he had of his daughter back. And that's, like I said, that's only one anecdotal story, but there's a ton of them out there, and even the literature backs that up. So, I think that there's a possibility that we could save a huge amount of healthcare costs on mental health treatments, mental health medications, and then prevention of ER visits if the insurance companies would cover this for a fair amount of people.
I would assume, and I don't like to do that, but I would assume the people that are coming into your door are already ready to go, right? The problem you have is what you said with the insurance, right? Or them being able to afford it. So are you ever having to kind of talk anyone kind of, I don't want to say off the ledge, but talk people into it? Or when people come through your door, is the thing that you guys have to worry about the most is, can they afford this?
Yeah. So a lot of this, it's funny that there's so many patient advocates for this, that the patients that come in seeking treatment are almost as knowledgeable as I am about the medication. I mean, it's very rare. And now that it's getting out there a little bit more, I actually have a little bit more of the patients who have some hesitation and kind of need to be talked through, like exactly what we go through with the procedure. But 3 or 4 years ago, it was literally everybody who was seeking that type of treatment they knew the studies, they could tell you how ketamine worked, and they were convinced that was the right treatment for them. And like I said, this isn't, you're not just coming in to get your little ketamine dosage, and there is a risk of getting addicted to it. But most of these people have been in psychotherapy for years. They're on antidepressants or anti-anxiety medications, and they're just still having like crippling symptoms. And so those people by and far are just looking for a solution so that they can feel like a normal human again. And so they are definitely the ones who are absolutely finding out everything about ketamine before they even come through the door.
And you brought up the risk of getting addicted to it. Now, is that the ketamine itself, or is those the type of people that are going to get addicted to whatever?
Right. And that's where we don't know. I mean, I think that probably a lot of it is probably an addictive personality disorder, where in the sensation that people get after the ketamine treatment, especially for those first 2 to 3 hours, there's elation, like you feel so good, like nothing bothers you if it truly works well. And so those people are trying to recreate that sensation every time that they come back in. And the problem, what you'll see is they'll say, well, the last dose was good, but like I feel like my dosage needs to be, brought up because I
Take it
didn't
to
feel,
11.
right. Yeah, exactly. Yeah. I didn't feel quite as good the last time that I had my infusion. And so that's where you really have to be careful, is you can't, if you let the patients dictate your protocols, then that's when you're going to run into a lot of issues with this.
And bringing up the protocol, what is that protocol look like? Is it different for each person? Do you have a time span that there's a hard cutoff no matter what, that you try to wean people off? You say you get lesser and lesser each time to where there's nothing. Are they allowed to come back in 6 months? How does that work?
Yeah. So the standard protocol basically in the literature is that you get those 6 treatments, and it initially used to be over 2 weeks. Now they've kind of moved it to 3 weeks. So I give a lot of variability of those first 6 treatments based on how the patient reacts to the treatment. And then after that, it's kind of completely variable at that point, that sometimes those 6 treatments will last for 6 months. Sometimes they may last for 2 or 3 months. They need a little booster dose, and then they go for 6 months. My ideal circumstance would be that we give them the 6 treatments, maybe a 2 or 3 booster doses throughout the next 12 months. And then we're on a pattern where at most every 6 months, you're having to get a booster dose. I feel that I've failed if I'm getting, under 3 months, under 2 months with those booster dosages. And I will not do a booster other than right at the beginning. I'll give a little leeway. So if we get the 6 treatments in and 3 weeks later they feel they need a booster, I'll give the booster then. But if we're getting to the point where they're requiring a booster every month, I don't think that the treatment's effective at that point. So, and like I said, the literature out there, that's where a lot of this variability, we're just not finding, why certain people do great and go 6 or 12 months with a booster or without having another booster, and then others need it much more frequent. And I think that's going to be the variability until we get more of an idea of, like true personalized genetic medicine. And then we're going to know, oh, ketamine's going to work perfectly for you. Ketamine may not be the best choice for you because the cost is going to be prohibitive because you're requiring these boosters, monthly, and probably some other treatment may be a little bit better.
But I also think too, the thing to consider with maybe the people that are saying they need to do it more frequently is similar to what you see within the plant medicines and the psychedelics and the psilocybin and stuff, is that you also have to do some work on the back end as an individual in terms of integration, and you have to, it's not a magic fix. Sometimes you can get that elation, and that can trigger the response of like, okay, I need to make these changes in my life. But if you get that quick fix and you feel elation and you're good, but then you're still not making your bed in the morning, you're still eating like crap, you're not exercising, all these other things, that could lead to not getting the results that some other people might be doing as they're getting that elation, but then they're also making the changes. Maybe they're incorporating meditation. Maybe they start journaling. Maybe they start getting away from certain friend groups and stuff like that, and they're making these changes in their lives. So that's something probably that could be a factor as well.
100%. Yeah. And that's where, I basically, like you said, I give them homework after we're done with those 6 like when you start to feel like you're trending back to how you felt before the ketamine, this is what we need, you to do. We need to go outside. We need to get sunlight exposure. We need to assess, is your diet, like you said, is your diet not right? Is your friend group not right? Are you drinking alcohol to excess and that's what's causing issues? Are you, and we screen them for drug use beforehand. Are you doing something where you shouldn't be doing, and we know that this is going to set you back because of the deleterious effects of whatever they're taking in.
Well, I'm curious too, with the screening and stuff like that, do you get, or have you gotten some people that are maybe coming in more from like an exploratory perspective of like, hey, I heard this on Andrew Huberman, or I've worked with plant medicines, or I've done these certain things. I have experience with psilocybin. I want to see what this is about, not necessarily that I have high stress or anxiety or I'm dealing with depression.
Not yet. I haven't seen that yet. So that was the other caveat with ketamine, is that unfortunately over the last year, there's been a national back order of getting IV ketamine. So you have to basically, now I go through a compounding pharmacy who basically compounds the treatment. And so they won't send vials that I can pre-mix or that I can mix in the clinic. I have to get pre-mixed vials, and then I adjust the dose based on, I get a dose of what I think is going to be the upper limit of what we would use, and then I have to adjust the dose in the clinics. So I think a lot of things, when the shortage goes away, then we are going to have a lot more people in the door, and then more who are, just with the knowledge out there and all the podcasts that go through it, I'm sure I'm going to get those people through the door who just want kind of an experimental treatment at that point.
So you brought up the reintegration part of things and how you have homework for your clients. And another thing we always hear talked about in these realms is set and setting. And I know with some of the ketamine clinics we've talked in the past, they have the eye shades and they have the music when the people are getting the IV. What does your clinic look like in the process of that? What does the set and setting look like?
Yeah, so they come in the door, and basically I have spa music playing overhead, and then they get, I provide them with Bluetooth headphones, and I curate the playlist based on some of the psychedelic researchers up at Johns Hopkins has made playlists that I will then change. And then I can have the patient tell me, hey, I like this one better. I like that one better. I give them personalized logoed eye shades as well. And then I put a weighted blanket, a warmed weighted blanket on them as well. And then they have the opportunity to, if they want like an infuser or a infuser in the clinic. So like we'll put lavender or something like that on if they would want some type of scent as well. Sometimes I'll avoid it because it can distract them from the ketamine treatment itself. But yeah, across the board, they're basically getting sleep mask, they're getting curated playlist, and then they're getting the weighted blanket, and they're in a recliner in the clinic in a basically at a 45-degree angle reclined position as well.
So you bring up that curated playlist, and I like to get woo-woo, so I listen to all that stuff. Is there any artist on there, or is it just something that Johns Hopkins made themselves?
It's basically, yeah, one of the researchers at Johns Hopkins basically made himself, and I don't even know. I mean, there's no specific artist that I'm even familiar with, and I can't even remember offhand what the playlist is. But yeah, it's music that I'd found when I was researching online before I started the clinic that, and some of the clinics will let people listen to their own music. Sometimes I don't know that that's the best thing. I mean, if a person comes into the clinic, they've done it before and that's what they're going to want, then by all means, if it's been effective for them, I'll let them do that. But I think someone who's not, this is a novel treatment for them, is going to do better if we do those curated playlists that they've actually done studies behind.
Got those on Spotify?
Yes, I did.
Is it under Johns Hopkins?
Yeah. So if you look up psychedelic treatment on Spotify, there's probably 10 to 12 playlists on there.
Okay.
And so that's what I said. I can't remember offhand. That none of the artists seem to be familiar. But yeah, they have curated playlists that are from 45 minutes long to 4 hours.
Okay. And so with that being said, from walking in the door, getting the eye shade, getting the Bluetooth headphones, sit down in the recliner, how long is that? I was going to say ceremony. How long is that session? How long
Right.
does the session last for? Then um, I know in my experiences, driving isn't really necessarily a good thing when you're coming off of ketamine. So I was curious, like, is there like another waiting room where they go to recover from that, or do they have to have someone pick them up?
Yeah. So they have to have someone come pick them up. So they'll come in the door. We'll have, and I've already had the preliminary like hour-long consultation, answer the questions, make sure they don't have any questions or anything that I need to answer or we need to address. Go over, their current treatment. So what antidepressants, anti-anxiety, who's their therapist, what's their therapist been doing, how often are they seeing their therapist? And then when we go to the actual infusion day, they come in, go through everything I'm going to do again. And that takes about 15 minutes as we hook the IV up, and then get everything primed and ready to go. The infusion goes over 45 minutes. And as they start to come out of that state, the state from the ketamine, or they reemerge from the ketamine infusion, then it takes about 15 minutes. We check their blood pressure, make sure that their blood pressure is not sky high, because like I said before, that can be one of the side effects. Make sure they're coherent, they can walk, they're not nauseated, not going to vomit. And then, yeah, everybody has to have a driver to take them out of there. So, and then they can't make any decision, any important decisions over 24 hours. They're not supposed to drink alcohol over 24 hours, no drug use over 24 hours, no, basically nothing that requires a large amount of brain activity for the next 24 hours.
Okay. And are you or someone on your staff, or is there like a sitter that's in the room just to monitor that 45-minute period?
So we have them on a monitor the whole time, and we're observing the monitor and we're walking by the room, just to make sure, because they're on a pulse ox, so we know that the respirations are fine. They're on a blood pressure monitor as well, and so we're getting their heart rate and their oxygen level. So if there was anything, like, we observe them breathing and make sure that everything's okay, and then that, we're going by the room every 3 to 5 minutes just to make sure that there's nothing abnormal. Sometimes they'll be, they get in such a state that they'll cry out, or get very emotionally involved in what they're going through. But we just make sure that it's not like a major issue where they're completely having, hallucinations and it's freaking them out too much.
Have you seen that at all?
Not yet. So
No.
I have, yeah. And in the ER, I've seen it a couple times, where people, they don't like that. You can tell. And then you give them something to kind of calm them down, and it calms them down. But then after they kind of reemerge, they come back and say, please never give me medication again. And that's where I go back to, excuse me, part of, I think, acceptance of ketamine treatment or the success of ketamine treatment is that you've got to accept it before you go into it. If you're being given it and you're resistant to it, inevitably it's probably going to fail you and what you're hoping with the outcome. So there's homework before, and then there's homework after as well. So, a lot of these people that if they do accept this is going to help, or this has the potential to significantly help, do much better than people who are hesitant about going through treatment.
Jason, you guys offer more than one service at Upstate Ketamine Clinic, and we were talking before about optimization, getting that sunlight, getting exercise, moving, all that stuff. How, I know you do testosterone optimization. Is there a point in time when males come in that come in for ketamine, and you might look at them or say, hey, we might need to get a panel, because I don't think your depression is caused by this. I think it might be caused by a lack of testosterone. And talk about some of the other services you guys provide as well.
Yeah, and so I think that's going to be the next phase of ketamine treatment, is the people that are resistant to ketamine treatment. Is it really their depression that's causing, the issues? And so, like, how the whole clinic evolved into from a ketamine infusion center to like a whole wellness center is, I've always been interested in like whole body wellness, taking care of your body. You take care of your body, it's going to take care of you. And as we've gotten so sick in the world, from bad diet, from not exercising, you just see this huge cyclical pattern of people getting sicker and sicker over time. So, and their depression increases. So is their depression increasing because of standard depression, or like you said, is it food related? Is it diet related? And is that bringing down the testosterone? Is it hormonally related? And so, basically my goal, and a lot of the patients I've had so far, it's been, let's try the depression angle and see how that does. And so far I've had good results, or they've gotten ketamine treatment elsewhere and they're coming in, they know it works for them. I think as the clinic evolves, we're going to work our way back into, if ketamine didn't work, then there's got to be something else, or there's most likely something else that is affecting your depression or causing your depression or your anxiety, or something else we could optimize, whether it be, is your thyroid out of balance? Is it truly testosterone? Because I think a lot of testosterone, comes back to thyroid and diet and those type of environmental exposures, because, male testosterone has dropped significantly, like 40% over a 50-year period, the standard testosterone level for a male. And so I think as the clinic grows, we're going to see more of this, where people may not have good results with one treatment, but there's another side of the clinic where they are going to get good results. And those people, hopefully, instead of just pushing them off to the side and saying, oh, ketamine didn't work, oh, well, it's a failed case study, that they're going to stay in the clinic because I've got another way to help them.
And you mentioned the VA a couple of times, and with the insurance and all that sort of stuff. Are you running the gamut in terms of who's coming to see you? Are we seeing, not to get, with HIPAA stuff and everything, but I mean, are you seeing veterans, soccer moms, college kids, or is it a specific crowd?
No, it completely runs the gamut at this point. I mean, you have, and I'll even get questions from multiple people who didn't come in for ketamine, who will be like, tell me about this ketamine. I've had people that just walked in the door. I've had physicians walk in the door who were just inquiring and said, hey, I don't know, this may work for one of my family members. Explain what you do. And so, yeah, there's a significant, I think, need out there, and or I won't even say misunderstanding, but they just don't understand it, and they're looking for some clarity of what this could actually do, because they're just not up to date on the literature or a lot of these clinics, because they haven't been exposed in South Carolina because there's so few of them. So yeah, it's a lot of education with a lot of my patients, and kind of just throw it out there, and they may decide it's not right for them at that point, but 2 or 3 years down the road, they may decide that now's the time, that I've read enough about it and literature's expanded and it's more mainline treatment, or what they would consider standard treatment. And we may see those patients back at that time.
And you find it because maybe ketamine isn't as well known as some of the other stuff that, that you see with MAPS and some of the other psychedelics and stuff, that there's maybe less of a stigma with it in South Carolina, and it's just more that it's kind of unknown?
I think that it's probably a little bit unknown still in South Carolina. I mean, I think there's a little bit better knowledge base with it than we would have had 5 years ago, but I still think that the majority of people have no idea that this is a treatment option for them, because if they did, they've either researched it and they've gone through the psilocybin, they listen to the podcasts that talk about treatment of depression, treatment of anxiety, treatment of chronic pain. They're Googling how can you treat chronic pain, and now ketamine infusions is popping up. So the ones that know that it's an option are the ones that are very in tune with trying to get better. The other ones who are just still just not knowledgeable about it are the ones who go to their doctor and here's your antidepressant, and maybe you go to the therapist, who are just not dialed in and just figure, well, this is how life is supposed to be. I think as those people get more educated about ketamine, that's where you're going to see a lot of those people that right now just are not knowledgeable about it, that are going to be coming into the clinics.
Okay.
And someone listening to this podcast that might be intrigued, who's living in the Low Country, who wasn't even aware of ketamine clinics and what ketamine can do, what's your pitch? What do we have to say to get them in the door, to get them to kind of scratch your head a little bit more?
Yeah. And it's just basically come in, I'm more than happy to do a consultation. I can explain everything to the patients when they come in, answer any questions. And like I said, you may decide that it's not for you, but I think that this is a treatment now that people need to know about, that it's out there and it's a good option for people. And it can significantly help. About 75% of people who go through treatments get a tremendous reduction in their medical problem that's causing, whether, like I said, the depression and the anxiety. So in a lot of the clinics out there are going to be the same way. Just come in for a consultation. Let's sit down. Let's talk. Let's answer your questions. What fears do you have? What can I do to make this more acceptable for you, or to make this a possible, option to get you treated and get you better?
And prior in the interview, you said 3 to 5 years, kind of looking at to get people on their insurance and be able to come through the clinic on the insurance. What's your long-term goal? What's your, say, 10-year goal for the clinic? I know you mentioned before going more towards the wellness as you start to integrate everything. What's your big vision look like?
Right. So like basically a whole wellness center. So I want it almost an integrated medicine, functional medicine type clinic. That's the basis for what I'm doing in the clinic. So I want people who come in who have a medical problem that the standard medical establishment has not been able to either figure out or treat effectively. And we're going to be that option that basically is able to either diagnose and I won't even say it's rare, but a lot of these become vitamin deficiencies or hormone deficiencies that the standard blood work, if you don't really dig into some of the other secondary tests, you're never going to diagnose. You get to spend 7 minutes with your doctor for the most part. They say, oh, you don't feel good. Well, your blood work looks great. I don't know what to do. Here's a pill, or go see a psychiatrist, or go here. Let me refer you here or there. So I'm going to hope that, we may bring chiropractic into the center. Like I said, integrated medicine. I want this to be, and I think that where medicine is going, we're in what like Peter Attia likes to call medicine 2.0 right now, where you come in with a complaint, here's your pill, your drug, and we get you out the door and deal with it there. Whereas medicine 3.0 is going to be more, once we get better genetic testing, it's going to be more genetic based, and it's going to be what's the root cause of the problem, and let's fix that root cause of the problem, instead of just giving everybody the same pill and saying this is the way that we treat everybody. And I'm sorry that you don't feel well, but you're fine according to our standards now. So, I mean, that's where my hope in 10 years is that people come here because either they want to feel better and they can't get a diagnosis, or they're tired of taking medications that just aren't effective for them.
Yeah, that's the one thing we hear too, with some of the hormone replacement people that we've talked to, or the podcasts we listen to, is that it's not necessarily about being in those normal levels, but what do we got to do to be optimized? And that well, you're at normal, but if we bring you to optimize, maybe you're going to feel better. Maybe it is the key to unlocking some of that depression.
Right. Yeah. And I mean, that's what you'll see. I mean, I have multiple people who are getting testosterone replacement who their level's 270. They're a 35-year-old healthy male who works out, and eats right, and their level's 270 and normal's like 250 to 800. And the doctor's like, well, it's in the normal level or normal range, but yeah, for an 80-year-old man, you're in the normal range. There should be no reason, if you're doing what you say you're doing, that your level shouldn't be 700-800. So we're optimizing for that level, and I think that's going to be, treat that, and then we need to go back and find, well, what's the root cause of all this? Why are all these males coming in and having significant decrease in their testosterone, who you would think you're going to the gym and you're eating what you should, and your protein levels are good, and you're not really eating sweets, and you're not drinking a significant amount, and you're not obese? Why are your levels in the tank as well? So I mean, I think that's going to be the evolution of the clinic, is that it's going to be try to get people better now, whatever way possible, and then go back and try to prevent it as we get more established, and more of a patient base out there.
No doubt. I'm going to be coming to see you.
Excellent.
Heck yeah.
Mentioning the whole integrative wellness and the kind of long term right now, do you have any packages where someone can come in, get ketamine therapy, get hormone optimization therapy, stuff like that? Or is it just you come in for this and then maybe we'll work on this? Or is that something you're working towards as well?
Yeah, that's what I'm working towards at this point. So everything's kind of piecemeal, just because it's such a novel thing to try to integrate everything together. And like I said, there's really no guide stones out there of anybody that's trying. You either have a ketamine clinic, or you have a functional medicine clinic, or you have testosterone replacement, or you have, IV infusion therapy with IV vitamins. It's everybody is kind of piecemeal. And I think that people are starting to put it together, that maybe a combination of everything may work out well, but I don't know how to integrate that into a huge package that's not going to be cost prohibitive for most people. Like you just can't pay $600 a month or something, to get all these, the treatments. So that's where I'm trying to figure out, like, how can we make it affordable for everybody and provide all the services that I still, can run a clinic and pay myself a decent amount too. So, that's where I'm going at this point of trying to figure that out. So I think it's going to be a work in progress, and it may take a year or 2 years. And, over time, as more patients come in the door, I'm sure I'll get it figured out. But right now, it's kind of, you're out there I'm out there on an island of how to do it.
Wishful thinking on my end, but I see the vision. I see where you're going. When I went on the website prior to the podcast, I was looking, I was like, all right, I see what he's doing. I like it. So keep it up.
Absolutely. Thanks, Jimmy.
Is that something that could be a thing at a certain time? Like, you get like your vitamin bag, your glutathione, all those stuff, but at the same time, you're going and getting all in one infusion, getting some ketamine thrown in there too? Or is that not, can't put those things together?
Well, you would probably have to do two separate.
Yeah.
Yeah. So, I mean, and that's, what I would really like to know, is if we do provide vitamins before we do a ketamine infusion, is someone going to get a better response from it? Or if I give them on a ketamine infusion and then give them vitamins 2 days later, and you're not going to get a whole lot of studies out there short of the big research centers. And I don't even know if they're looking at that, because there's no money to be made really from a drug company from ketamine or IV infusion. So, this is going to be kind of like a trial and error of, hey, okay, I did well on my ketamine, and then 3 weeks later, I started to feel bad again. Well, let's maybe try a vitamin infusion first, see how you do, see if it perks you up, and then maybe go to the ketamine. And so that's where I think a lot of this is going to be just me with the patients and trying to figure out a way to optimize their treatment regimens, like you're going to come in for ketamine. What can we do to increase the likelihood that you're going to have success with ketamine? And that's what no one is out there asking at this point.
Interesting. Well, if you're going to run some clinical trials, I know two guys that'd be guinea pigs for you.
Guinea pigs. I could get cheap flights to Greenville.
That's right.
Curious, have you ever done any therapy with ketamine?
So I've never done ketamine therapy.
Okay.
I was just too nervous with being in the emergency department and possibly getting drug tested, even though it shouldn't stay around in your system for long, and its acceptance until recently was, and it's still, acceptance in the traditional medical community. When I told people that I was starting the ketamine clinic, 95% of people are like, why are you doing? I mean, that's what are you doing? Essentially like, oh, that sounds like not a good plan for you to do. So I've been very hesitant to push any boundaries just because I don't want to get in trouble. I still work occasionally in the emergency department, and I don't want to lose that potential to be able to work a couple shifts in the ER then as well. So unfortunately, no, because I really, the results that people have gotten from it, I kind of want to see, even though I don't feel like I'm a depressed person, anxious person, don't have a whole lot of pain, generally pretty happy, but everybody has their moments, and I'm wondering, hey, would that give you just a little bit of mood boost there that may make your next couple days a little bit better than what they could be. So.
Yeah, I was just curious. Mentioned the ER. Do you miss that sort of intensity of that kind of medicine?
So not too much anymore. I mean, I did emergency medicine. I practiced, if you include residency, for 21 years. I've kind of seen almost everything there is to see. I've been through every adrenaline seeking situation there. I still like to go back and work occasionally, but my life is much better, and I feel like I help a significant increasing number of people in my clinic than I ever did in the emergency department. I mean, we're just so broken as a medical society where the road answer to everybody is just go to the ER. Well, I'm a Band-Aid station there. Like if you're dying, I can certainly help you out. But if you have this chronic condition for 4 months, I'm not going to be the one that's going to diagnose it that day. So, you get frustrated because you went into medicine to help people. And I feel the emergency department now is almost like the antithesis of helping most people. It's more of a burden. It's the net, the safety net of everybody, and people don't get the care they need, and it's just so disjointed. So no, I don't miss at all.
Okay, cool.
Yeah.
Thank you for sharing.
Yep.
You do the hormone optimization. I would think that you're getting blood panels on people, checking their levels. Have you ever done that after the ketamine sessions to see if there's any change in people's levels or their blood work or anything?
That I have not, and that's probably next on the horizon. Like I said, I'm trying to figure out how to make it a cost-effective thing, and then also or cost-effective testing, and then get information that I need from it as well. What probably will happen is start to get standard panels when they come in the door, see the panels afterwards, and I can work that into the cost of the treatment then, or the cost of the package essentially. Then I just haven't been able to institute it at this point. So like I said, with us just opening recently, and getting protocols in place and kind of racking your brain to how can we fix this, you almost need to start somewhere and start like everybody else is, and then kind of advance your clinic as you kind of see, like you have that long-term vision. And so it's coming, but I haven't gotten to that point yet that I've been able to check lab work and see kind of where we sit on the improvement, or if there is any laboratory improvement in these patients after they receive treatment.
Yeah, I'd be very curious to see if there is anything on that side of things.
Absolutely.
First question, are you a coffee drinker?
Occasionally. So I used to drink more when I was working full-time in the ER because that would keep me going. Now it's kind of hit or miss. If I'm in the ER and they offer coffee, then I will take it. But I can go weeks on end without coffee and not have an issue.
Because you have optimal hormone levels.
That's right.
Is that caffeine across the board or just coffee?
No, just coffee. So I'll drink energy drinks or pre-workout occasionally. But like I said, I can go days without drinking caffeine and be fine. So it's not, for whatever reason, caffeine has never really affected me. And I don't know how much it's affected me on the positive side or the negative side. I could literally drink a Monster before I went to bed and I would fall right asleep. It wouldn't affect me at all.
Oh, wow. Is that your go-to Monster, or do you have a?
No, I like Ghost.
Ghost?
Yeah, the Warheads Ghost, the sour. Yeah.
Okay.
So, yeah, that's my go-to when I stop at the gas station and am tempted.
How about you have a go-to pre-workout?
110%. So there's a local place called the Nutrition Store that keyed me onto that, and they I forget who even makes it, but it's called 110%, and it's good. It's got a good combination of caffeine, beta alanine, get you a little tingly and ready to go. That's right.
All right, we like that. Jason, do you have any daily practices or rituals that you do on a regular basis to show up as the strongest version of yourself?
Absolutely. So I work out at least 6 days a week, if not all 7, and I'm active. I'm making some even active recovery on the 7th day. I stretch every day. I started that about 6 years ago. I was getting to the point where, and that's kind of how my journey with optimizing my health came. I realized that I was trying to bend down to pick up a piece of paper from the floor, and I could barely do it from standing because my joints hurt, my back hurt, and I realized that I just can't keep going down this path. I'm going to have surgery or be unable to live the life that I wanted to. So I started stretching back in 2017 and have not missed a day since that time. And then for the last 4.5 years, I practice 10 to 15 minutes of Spanish every day. So just to keep my mind active and to be able to communicate with patients in the ER that I wasn't able to communicate with before. So I'm getting to the point where I'm fluent enough I can get by with a conversation. I won't say that I'm fluent enough to completely hold a very high level discourse at this point.
Okay. So 2 questions there. Is the main means of exercise or working out functional fitness type stuff or weightlifting?
Yes. Yeah. So mostly CrossFit-esque type stuff. And then we do 1 day a week swimming. So on Thursdays, then just straight swimming. So, and we'll do interval swimming, essentially anywhere between 50 yards to 1,000 yards, and then break it up. It just depends.
Okay. And then, have you practiced Spanish enough that you've had a dream in Spanish yet?
No, I've not had a dream in Spanish. So
okay. Always curious. I have a bunch of students who are from South America, and I ask anytime I meet someone who's either practicing or bilingual or trilingual or multilingual, I'm always curious how they dream. Do they dream in their native language? Do they dream in English, or vice versa? So
yeah, it may be that I do my Spanish like first thing in the morning. So I usually get up about 4:15, and sometimes I'll wake up earlier and I'll do the Spanish that early. So I'm never thinking about Spanish before I go to bed.
Right on.
That's a very inspiring daily practice, by the way. Make me feel kind of like not like I'm doing enough. So thank you for that one.
Yeah.
Jason, what are you listening to right now? Music, podcasts, audiobooks? Are you reading anything?
So I'm basically listening to straight podcasts. And I listen to Andrew Huberman. I listen to Peter Attia. I listen to Mark Hyman. I listen to a podcast called the Survival Podcast, which is kind of across the board, like not just a end of the world type stuff, but like how you live and optimize your daily life. So between finance, gardening, that type of stuff. And then the latest book I read was Robert F. Kennedy's Jr.'s the real Anthony Fauci.
No, we'll have to. That's another podcast.
Jason, you mentioned being a Huberman fan. Have you heard the podcast he did with? He was on Rick Rubin's podcast with Jack Cruz.
I've not heard that one.
It's so forewarning. It's like 6 hours. It's 2 parts.
Yep.
But if you're into Huberman, you're into all that stuff based on this conversation, I think you're going to eat it up. Look into it.
Okay. Yeah, that's perfect. That's what, when he had Andy Galpin on, you know, and those were all 4 hours and he had like 6 of them. I mean, I still ate those up. That's like right up my alley with between training and the medicine behind it. And I could listen constantly. So I will definitely look that up.
Check it out.
Did you listen to his recent one he did on ketamine?
I did. Yep. Yeah. So, I mean, that's a good, and I think as more people like that, because his audience is going to be more in the know. And what I mean is people who are very in tune with their health and want an optimization of their health. Like the more that we get those podcasts out there, the more likely you're going to see, or I'm going to see more patients that are coming to the clinic seeking out treatment, as opposed to having no idea that this is even a possibility, you know, like we saw 3 to 4 years ago.
Yeah. It was pretty. I find with Andrew's stuff, I have to hit pause a lot and either write stuff down or go back like a couple times, hit the 30-second back button to like really need to be in a good headspace and really focus. I've been doing it on my commute lately, where I'm just kind of like got nothing else to do but listen. So
yeah,
it was a good one. Jason, last but certainly not least, do you have a guilty pleasure or guilty pleasures?
Guilty. I guess a good bourbon is a guilty pleasure. So, and I try not to do it frequently because it is not optimizing my health. But yeah, there's sometimes nothing better than sitting down and after you relax and having a nice glass of bourbon.
Okay. Do you have a particular brand or?
My latest one that I had is the Whistle Pig 12 year. So it seemed to be, it was fantastic.
Okay. All right.
But other than that, I try to minimize my guilty pleasures.
No doubt. I find that brown liquor makes me ornery, so I tend to avoid that. But lately I've been trying to keep myself optimized. So even the craft beers I've been avoiding pretty much since I've been in South Carolina.
Yeah. That's I used to be a big beer drinker, and it's just the bloating now. Like I just can't drink like I used to.
Yeah.
And it's probably my body telling me that's a good thing.
Yeah. I've noticed the biggest thing is especially now that it's so infrequent, is the sleep. The sleep quality. It messes with my sleep quality so much that it's just, no matter how good it is or how much someone raves about it, I'm just like, you know what? I don't want to be tossing and turning on a Saturday night. So I'm going to pass.
Give me a hop water.
Yeah. Hop waters are really good.
Yeah.
Oh, yeah.
I haven't had it yet, but I will, you know, I've seen it out there, and I just, I didn't know how the taste was I assume it tastes like beer or.
Yeah. I mean, if you like hops,
yeah,
like that aspect of
Yep.
like an IPA,
Yep.
then you'll probably enjoy it. Jimmy just graduated from film school, so we were back home. And so different people that don't necessarily like craft beers, they make the same face when they drink the hop water that they do when they take a sip of a craft beer. But I enjoy them. I enjoy the taste of it. I've actually the last 2 ultra marathons that I've done, I've drank in them on the course.
Okay. Yeah.
So.
Nice. Excellent. Yeah, I'll definitely have to try that then.
Thank you for your time, sir.
Yeah.
This was a really great conversation. I really enjoyed it. And just listening to you, I just wish nothing but the best. Hopefully, when I'm in Greenville, Richie and I can stop in, because I see nothing but big things for you, sir.
Absolutely. I appreciate the opportunity, and good luck to you guys on the podcast. So I went back and listened to a fair amount of episodes that I could squeeze in this time. So, I mean, it's the content's fantastic. So I learned a lot, even in the few short episodes I was able to listen to.
Yeah, thank you for listening. And I'll probably you'll probably be seeing me within the next 2 or 3 weeks. I'm gonna get my work schedule, everything, and then I'm gonna drive on out and see you.
Okay, perfect. Yep, just let me know, Rich. That'd be great.
Awesome.
All right.
Jason, appreciate your time. Have a wonderful night.
Thank you, sir.
Thank you. Thank you both. Have a
Take
good
care.
night.
Take care.
Later.
Bye.